Welcome to another edition of Vital Times, the California Society of Anesthesiologists podcast series. This is Dr. Ludwig Lin. Today, I'm really honored to be in the company of two incredibly accomplished women in their respective fields who will be talking about the personal journey with complex regional pain syndrome and the pathophysiology, treatment, and science being worked out for that debilitating illness. CoCo Vandeweghe is an American professional tennis player. She achieved a career high world ranking of number 9 in 2017 when she made the semifinals of two Grand Slam tournaments, very big deal, the Australian Open and the US Open. She's known for her powerful serve and strokes. She's from a family littered with accomplishments, including Olympic and national team swimmers and water polo players. She was knocked out of her sport in early 2019. After a lot of uncertain times, which we will discuss in this podcast, she was diagnosed by Dr. Vivianne Tawfik at Stanford with CRPS, and CoCo has beaten all odds to return to an elite level of professional tennis. This August, she won a professional tennis tournament in Concord, Massachusetts. Dr. Vivianne Tawfik, MD, PhD, is a prominent physician scientist at Stanford University School of Medicine in the Department of Anesthesiology and Perioperative and Pain Medicine, who specializes in the treatment of complex pain disorders, including chronic postoperative pain, complex regional pain syndrome, and peripheral nerve injuries. Dr. Tawfik is the director of the Stanford Fellowship in Anesthesia Research and Medicine FARM program, and she conducts research in the immune contribution to persistent pain using clinically informed basic science, while also caring for patients suffering from chronic pain. So I'd like to thank both of you for being able to join me today for this podcast. I think it's going to be really informative, educational, and inspirational. CoCo, I'm going to start with you and your story. So if you could just fill us in, what do you think was the initial injury and when did that happen?
Well, that is kind of definitely a long ongoing theme in my career. Is in tennis, the season is so long. You start January 1st and you end sometime in November. So it's a very long season, and you start your preseason for the next year around Thanksgiving time. So it's basically never ending. And unfortunately, I'd spent the last 2 years before being diagnosed trying to recover from various injuries that you get while playing tennis. Different bumps and bruises, I would say, in comparison to what I actually ended up having to deal with CRPS. I've always had ankle issues, foot issues. So it was definitely not my first rodeo going into a season that I had finished injured. And so I finished 2016 just a little bit injured. I had some bad arthritis in my ankle. It was actually my left ankle. And I was booted for most of the off season. I actually had time to be scuba certified in that amount of time just to, enjoy myself a little bit. But I started 2017 with a bang, as you said, making the semifinals of the Australian Open and losing to Venus Williams in the semifinals. I ended up following that up by making the quarters of Wimbledon, losing to Maria Sharapova in the quarterfinals. And I finally capped off that year playing at the US Open, losing in the semifinals to Madison Keys. And it was definitely a long year. I continued to keep playing into November, representing my country in the Fed Cup, which has now been renamed the Billie Jean King Cup. We won it for the first time in 10 years in Belarus. So my season finally capped off November 12th. And I was extremely exhausted, extremely burnt out, but couldn't have been happier, finishing career high, number 9 in the world. And being able to represent my country is definitely the best thing that's ever happened to me. I've been able to represent my country in the Olympics at Rio in 2016. as well as throughout the years in various team competitions. And going into 2018, I came in very exhausted, very burnt out. Like I said, I actually didn't compete much in the early part of the year. I was unable to defend my semifinal run at Australia. I was under the weather. I had the flu for most of my trip to Australia. I couldn't seem to kick it. And then I got to the States to play Indian Wells and Miami, two very big prestigious tournaments, and bowed out early. I won the doubles in Miami, and I ended up going to Europe with not many singles victories under my belt. And going into Europe, you start on the clay court season leading into the French Open. And I was able to make the finals of Stuttgart. I almost won a Porsche, actually. I just missed
Nice.
out on a Porsche, but I had a great successful run. So I started to pick back up on being loving being back out on the court in singles. Or just being out on the court in general for tennis. And going into Wimbledon and the grass court season, it's definitely been my most successful surface in tennis. And unfortunately, I took a step to hit a forehand like I do numerous amount of times, and I just felt my ankle absolutely crunch. And it was my right foot. I ended up having bone spurs, and it wasn't that big of a deal because it would swell up, it would hurt, but I took a couple months, well, not even a couple months, just 1 month off to try and rehab it. And I personally decided to call my season a season. And I talked with my team, my agent, and my coach at the time. And unfortunately, I was talked out of it. So I continued to play with these floating bone spurs in my right ankle. And unbeknownst to me, I had already a stress fracture in that same foot. So I was playing with this. And so my solution was let's just tape it up more. I already compete in ankle braces. Let's tape it up underneath. And so I kept taping it more, taping it tighter. I'd take it off and it'd swell up. I'd ice it down, and it was just a repetitive, get physical therapy in my foot just to try and get the swelling out and just continue to play. And I actually ended up winning the doubles title at the U.S. Open that year in 2018, and it was my first Grand Slam title. I basically did that with a broken foot. I would equate the feeling of what I was playing on, and so
Wow.
I had to continue to play the rest of the year. Silly WTA rules at the time. If you're top 10 in the world, they commit you to tournaments throughout the year that they need you to play. They call it mandatories. And so I had to go to China and continue to play and compete. I could not finish a single match. The pain was just too much for me to play singles. And I ended up having to say no at the end of the year for competing for my country. They were playing in the finals again against the Czech Republic this time. And I had to say no because I knew I would probably be put out onto the singles court and I could not finish. It was not capable, but unfortunately, the rules that the WTA had put out, which are now no longer in effect, I would be fined for every event that I would do not play. So it was less expensive for me to show up and play injured and in pain than to stay home, rehab, and pay the fines for me not showing up. So I ended up rehabbing once I was able to get home in late October. And I ended up rehabbing, feeling pretty good about where I was back to get going again for the 2019 season. And to start up, I entered this exhibition play in Hawaii, which was a guaranteed 2 matches because I wanted to play matches since my singles season was kind of cut short. I hadn't really played a full singles match since July, where I hurt myself at Wimbledon. And I ended up going out there The day before practicing, going through what I normally do, taping up my foot like crazy, as well as wearing the ankle braces. And I was like, man, I feel like I have turf toe. So the physio that was there taped my toe down because I've had turf toe before. Taped my toe down. It's all happening on the right foot, and I have my toe taped down, my ankle taped like basically a cast, and then my ankle brace all on one foot. And I play my match the next day just like that. So I went to dinner with my younger sister and my coach at the time, and I was kind of limping a little bit. And I always kind of take care of that foot, but this was a lot worse, and I was in pain. And I kind of always walk with a bit of a waddle just to kind of counteract the injury that I've had from Wimbledon, just taking care of myself. And I next day waking up, still feeling not great with the pain. And my coach said, well, let's just take the day off, take it easy, go to the beach. So I went to the beach with my younger sister and came back that night. And I really had a hard time standing up. I really had a hard time walking. And I was like, my gosh, maybe I broke my foot. I have no idea. So I go back to sleep the next day. That night, next day to wake up, I go to try and stand up to use the restroom, and I cannot make my body physically stand up. I'm like in so much pain, and it's swollen, it's huge, and I'm trying to make myself stand up, and I don't know how or why or what, but my body just would not allow me to stand up. So I crawl to the bathroom, and I call my mom, and I'm like, I need to come home. I think I broke my foot. I have no idea what's going on. And so I had to be wheelchaired out. I got a flight that night from Hawaii back to California. I landed Christmas Eve, Christmas Day, went to the ER to get an x-ray to see if it was broken. I still can't walk. I can't physically make myself stand up. And I'm, wrapping it every night just to try and compress it and taking care of it like I normally would for an ankle sprain or swelling. And still can't stand. X-ray comes back negative. Okay, now I got to wait for an MRI because it's the holiday season, and so I get an MRI. Doesn't say anything. And the orthopedic surgeon I went to, he's more of a shoulder guy, but he was able to order me the MRI. He said, well, I don't see anything on here. Like, I mean, nothing should be wrong. And I said, well, look at it. It's swollen. It's bright red. It hurts for anyone to touch it. I can't even put a sock on. I can't stand. When I stand for any amount of time, like holding on to something, I get nauseous. And he's like, the MRI says you got nothing wrong. So now I'm just like in search mode to be like, what the heck is wrong with my foot? He said, well, you were in Hawaii. Maybe you stepped on a foreign body. Maybe, I don't know. And so I'm like, just searching. And a month goes by, still not walking, still not standing. I'm still trying to get physical therapy done on it. And they're just trying to get the swelling down. And the therapist I was using, he didn't want to say CRPS because it's like, oh, that's the worst thing that it could possibly be. And I'm just doing every test I can possibly do, blood tests. They even thought I had a bone marrow infection. The amount of tests I went through and blood drawn and scans and this and that was 2 months long. And finally I went to a doctor to, maybe I was allergic to something. Like, that's how far I got down the list. And he's like, I'm about to retire. I haven't seen one of these cases in many, many years, but doctors just don't learn everything anymore. I mean, he was an older gentleman. He said, I know this person at Stanford University, and she works in this field, and maybe she can help you. I was like, listen, anything. I just want to know what the heck is wrong with me. And I'd finally gained the ability to walk, but with only a short amount of time before I was, either nauseous or in too much pain to kind of handle it. So that's how I met Dr. Tawfik, and She was able to give me the diagnosis, which was probably the best clarity of the whole thing, was just knowing what the heck was wrong with me.
Wow.
So that
That's
that took about 3 months, I would say, to figure out what
mhm.
the heck was wrong with me.
Wow. That sounds like quite the journey. But let me ask you some follow-up questions.
Sure.
You said that you couldn't walk on it. A sock would induce like, you know, huge amounts of pain. Did you ever feel like your leg was like no longer part of your body? Did like
I definitely had no proprioception, mainly just in the foot area. So like I would misstep if I was just standing trying to get my feet flat footed. Um, I did not lose feeling of like where my leg as a whole was. I was very lucky; it was localized just in my right foot. But I mean, my pain was so severe I couldn't even have my bed sheet on my foot.
oh
And
wow.
if it was below my body, I would just get nauseous immediately. And so I was living off of a big crock pot of food for a while because I couldn't stand long enough to cook anything. I couldn't drive anywhere because it was my right foot. So I was definitely at the mercy of whoever would come around and bring me something to eat.
This is intense. So, what therapies did Dr. Tawfik have you go through, and what did you think of them?
Um, I couldn't quite comprehend what was happening. I was definitely in a super depressive state by the time I had gone up to Stanford, just because I'm top of my game, top athlete. I can run. I can do anything I want to, and I'm a very active person. But to have that taken away in a little less than 3 days was pretty shocking to me. And then to spend 3 months of having no ability, I just wanted to never not, I just wanted to walk again. That's all I wanted to do, let alone play tennis again. That was so far from my mind. I definitely did a lot of mirror therapy, which made sense to me in a way of like flipping flipping and tricking the brain, and she did a great job of explaining to me that it is your central nervous system. Your brain has to finally figure out that the pain, that you're going to fix the pain that's happening, and it's not it can allow you to go through rehab, and literally the rehab is as much pain as you can tolerate. And so me being a professional athlete, like I've gone through a lot of pain. I know how to push myself to unbelievable limits. And I was like, took that challenge on, and just was, I'd been on many of physical therapy tables, just sweating and just like trying to tap out, and telling the PT like, don't let me tap out, like just keep touching my foot with the different foreign objects, and going from a rug to a tile surface, like even something simple as that, trying to get my toes to curl. I mean, just trying to make it work, and it was disheartening a lot of times because the progress was so minimal at the start. But once I felt like I could stand comfortably and walk comfortably, that was where I saw the biggest progress.
Mm-hmm. That's amazing. I just wanted to pause real quick and just give you some kudos, CoCo, because I feel like you, by being so, determined and maybe stubborn and insisting on moving it, and like even when you were still trying to play tennis, that probably helped you a lot. That's just amazing.
I,
Uh,
I've heard different. I mean, many stories of. I mean, once my story came out about CRPS, of people that still are going through pain, and I can't imagine living in that pain for years. It's wild to me, and it's a wild disease, that's for sure.
so it took you about 3 months to get to Dr. Tawfik, and then you started
Hmm.
doing, your therapies that she and I will discuss. How long do you feel like it took before you were back as a human being? And then we'll talk about how long it took before you felt like you were an athlete.
It's that's tricky because my identity as a person is very much tied into my identity as a professional athlete and as a tennis player. It was getting back into being able to learn how to jog again, learn how to run again, get my conditioning up, feeling comfortable that I can cut and move. And then I was like, you know what, I'm just going to call up a friend and see if I can hit some balls. And that's how simple it started. Called up a friend and I hit for 30 minutes. And I was like, okay, I felt myself misstep still, but like I felt okay. And then it just kept going a little bit more, a little bit more. And it was actually August when I got approached by a team in San Diego. There's an event called World Team Tennis, and the team in San Diego offered me a match to play. And I was definitely not ready to play tennis, but it was kind of like a kid on a diving board. Like sometimes you just got to get pushed off a little bit, and I just was like, screw it, let's go, let's enter, let's play and see what happens. And I actually ended up winning the match, but I was it was so fun to play again and to have that identity back, people watching and friends, family, strangers, it didn't matter. It was so exciting to play again, and that was so exciting for me to get back out there. To play, and unfortunately COVID stopped me again, but it was just so exciting to play, and I entered myself into the US Open and got to play in New York in a place I love, and it is just so exciting to feel normal, because that to me is normal. Being a
Mm-hmm.
professional athlete is normal. Me sitting on the couch with my dog is awesome and I loved it, but that's not a normal aspect of my life.
Right. So it sounds like it took about 6 months. Is that right?
Yeah, 6 months. Therapy still continued for over a year and a half.
Okay.
And still, even now to this day, I still am diligent on doing therapy for my foot, for CRPS, because I suffered another terrible injury. I had full reconstructive surgery on my pinky finger. I took a bowl out of the microwave during COVID. It exploded in my hand and sliced off my pinky finger. So I had to desensitize the nerves, and let the surgeon know that I suffer from CRPS, and it's just going to be with me for the rest of my life. But luckily, I had no problems with it in my hand, so I was very fortunate there.
Good. So what therapies are you doing now for it? You mentioned that you're still doing some maintenance.
I still do a lot of desensitizing of the nerves. If I'm feeling like I am not getting full dexterity in my hand, mainly because I was at most recent injury, I still am very diligent to make sure I am stepping correctly. Because I still lose my proprioception a little bit. I think that's always going to kind of be the case. I still am diligent about watching myself walk downstairs, because that's where I lose it the most, is actually going downstairs. So it's constantly a work in progress. I try to stay barefoot as much as I can. I'm very careful of, if I do accidentally twist my ankle, which, it's part of sports, injuries happen, that like I'm on it straight away. I'm desensitizing what's my foot, or, if it's the left foot and not the right foot, I'm just very diligent on it now, because I never want to go through that pain ever again.
What were some of the treatment strategies that were suggested to you that seemed ridiculous, but in retrospect actually helped a lot?
Um, Looking in a magazine and actually identifying which foot is right and which one is left. I was
Mm.
like, this is the stupidest thing I've ever heard. I was like, I can look at or a photo and be like, which one's the right foot? And it was actually weird. I couldn't figure out which one was the right or the left foot.
Oh, wow.
It took me like a good beat. I was like, wait a second. But yeah, that,
Wow.
that one definitely felt the really the dumbest thing I could have possibly do.
Wow, there you go, though.
Yeah.
Okay, I want to progress to Dr. Tawfik, but I wanted to ask you one last question, which is if others with CRPS come to you for advice, what advice would you give them?
There's light at the end of the tunnel. I think when you're in that much pain and that debilitating state, it's very easy to get into your own little bubble and not feel like you can ever leave. I'd gotten such a dark hole that I was embarrassed to be seen. I was like, I'm a professional athlete. I can move, I can run. And I was just so embarrassed. I was like, I can't even walk. I can't even stand. And there is light at the end of the tunnel. There always is. There's a solution. And I'm very fortunate that not only myself, but my family was also very diligent in finding a solution for me when even I couldn't find a solution for myself.
It's good to have a village around you. That's great.
Yes.
And you know what? Thank you for that message. I think that's really important for people to hear because this is a very serious syndrome, and that's why we're here talking about it. CoCo, thank you so much. And I'm going to direct my questions now to Dr. Tawfik. So, Dr. Tawfik, let's go through some basics about CRPS. Maybe you could just share with us the epidemiology, the natural disease history, and the prognosis for people with CRPS 1 and 2.
Sure. Yeah. I mean, there's a lot in that question. So
We'll make
I'm
it
going to back
brief.
up a step.
Yeah.
Yeah. I mean, I think of complex regional pain syndrome or CRPS as really a form of chronic pain that is so relevant to anesthesiologists because it's a type of pain that tends to affect the limbs. So I think of like hands and feet, legs and arms, but usually after a minor trauma or a surgery. And as anesthesiologists, because we're often in the operating room at the time of the surgery, we're the ones doing the regional anesthesia before the surgery. We're the ones, on the pain service rounding on these patients after the surgery. We're involved in the intra-op management. We're sort of there during this key period during which, the risk of development of CRPS occurs. And so CRPS itself is diagnosed based on what we call the Budapest criteria, which were developed by a group of CRPS researchers about 10 years ago. And it really involves the presentation of signs and symptoms in 4 different categories. And those are number 1, sensory. So I think of that as pain. The second is pseudomotor symptoms. So things like edema and sweating changes. The third category is vasomotor or temperature and color changes. And the fourth is motor trophic changes, so loss of range of motion, tremor, weakness, and even hair, nail, or nail growth changes and changes in the skin. And I think, unfortunately, CoCo, was able to speak to a lot of those, describing sort of a red, hot, swollen foot that was so sensitive that she couldn't even put a sock on it or a bed sheet. And that's something I think is particularly characteristic of the pain associated with CRPS. It's that touch sensitivity to even, sometimes a light breeze. So those criteria are sort of how we think about CRPS. So you can tell it's sort of a different presentation than other types of chronic pain. And with that, we also think about 2 different types, type 1 and type 2. Type 1 is without a known nerve injury, and type 2 is with a detected nerve injury. And I think that there's a lot I could say about that designation. I think, sort of the high level is that maybe there are those 2 types. I think that's probably an oversimplification. And many patients where there's no major nerve injury detected, it's possible we just, haven't done a scan that actually can show us that there is a nerve injury. But sort of putting that aside, there are these sort of described 2 types, type 1 and type 2. And in terms of epidemiology, it's not that common. It occurs in about 5 to 25 cases per 100,000 patients per year, or about 50,000 new cases per year in the United States. But I would probably posit that it's underdiagnosed. And I think, again, CoCo gave us an unfortunately long story of how she sort of went around not knowing what it was and appropriately ruling out other things, but it did take a while to sort of get to the diagnosis and then be able to initiate a treatment plan that was specific for that diagnosis. So I do think that it is certainly under-recognized and underdiagnosed. There are some risk factors for CRPS. Some we can change and some we can't. So female gender is a risk factor for CRPS, about 3-to-1 females to males, just like many chronic pain conditions. A history of an injury or a trauma is a risk factor. And then immobilization or casting or some sort of boot or something like that after injury is also a risk factor for CRPS. And then beyond that, there's, certainly genetic underpinnings that we don't have, quite a good handle on. But that's sort of, maybe a high level answer to some of the questions that you asked there. I don't know if there's any other parts that I missed.
Yeah, let me ask you a couple follow-up questions about that part. So what percentage of people diagnosed with CRPS can return to their previous level of functioning? And maybe I could get you to answer that in terms of both people who don't get any active treatment and those who do get active treatment.
So that is a really hard question. I'm not sure that I can give you an answer.
Fair
So
enough.
this gets to, this kind of gets to the weeds, which is that the more I see patients with CRPS, the less I understand about CRPS. And I'm saying this as somebody who for about 8 years now has focused my pain medicine practice on patients with CRPS, and I do research on CRPS. So I think about CRPS a lot. And what I've noticed is, I presented this distinction, type 1 versus type 2, nerve injury or no nerve injury. But what I really see is that there's a lot of heterogeneity in the presentation. And so we have these criteria, but patients will meet those criteria in different ways. And so we have some patients who really present with, the way CoCo did, red hot and swollen after a clear injury. But then we have some patients who present sort of with, for example, I have a patient who had like a very shrunken and atrophic hand with contractures. And that's a very different presentation in my mind. And, if you look at sort of all studies and all comers, they also describe the sort of warm CRPS and a cool CRPS. And the warm CRPS tend to be the sort of more acute within the first year after the injury or the trauma or the surgery, and the cool CRPS being, longer term CRPS, that it transitions maybe from this acute to chronic or warm to cool phase CRPS. So I think, one thing that's clear is if you catch people early in that red hot swollen acute phase, then they tend to do better. And so, a large percentage of those patients will go on to fully recover and, maybe have to do some maintenance, physical therapy, be more aware of injuries, all the things that CoCo really nicely described for us. But then you have a group of patients who are maybe late to diagnosis, misdiagnosed, or just, whatever it is, didn't connect with the right doctors who knew what it was. And they tend to be harder to treat and more refractory to treatment, which is also why I love this idea of the podcast, because I think awareness is really important in this space, because, more people who sort of think about it, you present to the ER with a red hot swollen foot after an ankle twist, and somebody in the ER thinks, hey, yeah, maybe they're wrong, but it's just having the thought of like, could this be CRPS? I think is really important. And I think gets people to treatment earlier. So the very long answer to your question is, I think it's hard to say. I think patients who are treated earlier tend to do better. I think there's probably a group of patients who take longer to heal after an injury or surgery, but they may just kind of get better without treatment. And then there's some patients who come and I throw the kitchen sink at them and they still don't get better. So it ends up being a little more complicated.
Right. It seems like that time window when people do need to start treatment is about 3 to 6 months after presentation. Is that about right?
Yeah, I mean, the sooner the better.
Yeah.
And, I usually say within a year after injury, ideally,
Mm-hmm.
but definitely the sooner the better.
So I'm interested to pivot to a discussion about the possible pathophysiology. I guess for me, as somebody who loves, for example, regional anesthesia and thinking about nerves, but we're all in anesthesia trained about like like reflex pain arcs, etc. So there's like local mechanisms, there are spinal cord reflexes, and it seems like this doesn't follow any of that because, I was trying to do some preparation and I read about like this like glove stocking type of pain distribution that is not consistent with, for example, a nerve level or a spinal cord level. And then, as CoCo talked about, and you've already mentioned briefly, there's definitely some like central nervous system stuff involved. So, what is the pathophysiology involved in this?
Yeah, the answer is all of the above. So it means I'm going to have a very long career as a researcher because it's going to take a while to figure out. But yeah, there are peripheral mechanisms. So it's very clear that there's some sort of inappropriate, I like to call it exuberant inflammation that occurs at the site of injury. And so there is maybe a component of that autoinflammation, so that innate immune system reaction that's excessive, but then there's also some evidence for autoimmunity. So like a B cell may be mediated reaction where B cells start to attack self antigens in an autoimmune type phenomena. And that's sort of happening peripherally. But then as you sort of sensitize the periphery, there's obviously hyperexcitability through those primary afferent neurons that go to the spinal cord dorsal horn. And that's where, my cells of interest are located, microglia and astrocytes, or the glial cells of the central nervous system. And we think that they're also involved in that they can sort of release cytokines and chemokines and, these sort of pro-nociceptive mediators. And they can also further sensitize the circuit. And then there's a role for the brain and how, the cortical representation of the injured limb changes over time. And, I think you asked this question of CoCo, is like, did you ever feel like, the limb was non-self, or, did it change your relationship to the injured limb? And there have been studies showing an almost stroke-like hemi-neglect in patients with CRPS, and it sort of makes sense when you think about it, just sort of developmentally, if you're like, you get an injury and, you need to get out, for example, the battlefield, which is where this was also described, you're going to sort of ignore that your right foot is hurting because you need to get away. And so your brain just sort of walls off that right foot and no longer considers it to be useful. But then, that might help you get off the battlefield, but it doesn't help you if, you're not in battle and you don't have that, that context anymore. So the brain sort of does this. And it's also, like, people, especially like high functioning, successful people, want to just keep going, right? And so the way that we can sometimes deal with that is by ignoring an injured limb and moving on, retraining ourselves to become left-handed, for example, if you have a right hand injury and you're right-handed. So there are things like that. So that what we call limb laterality recognition, which is literally just pictures of right and left feet in different positions, or right and left hands in different positions, is a way of doing that cognitive retraining or brain retraining for cortical representation, which turns out to be really important.
Well, CoCo talked about that. You guys did the mirror therapy, and she talked about how she couldn't point to a foot in the magazine and realize which laterality it was. So she totally talks about this.
Yeah, exactly. And then the one last thing I should mention on pathophysiology is that, originally CRPS type 1 was referred to as RSD, or reflex sympathetic dystrophy. And there was sort of a whole movement that, and I think this is still valid, that there is a major sympathetic component to CRPS. And I think, over time, it's been sort of determined that not every patient has a huge sympathetic component, but certainly when you look at somebody who has a red hot swollen foot, you think of the sympathetic nervous system being overactive. And so that is definitely also an important point and an important part of the pathophysiology. But the relative amount of each of these mechanisms is not clear. So in one person, maybe they have more sympathetic component. In one person, they might have more peripheral sensitization with immune cell activation. In some patients, it might be more cortical. So I think probably, all these things work together within a single person, but part of what I describe as heterogeneity in clinical presentation may actually represent, different contributions of these underlying mechanisms.
Right. So it's sort of like the end result is the same, but like the different slices of the pie chart are different, sort of.
Yeah, or like if it also means that a treatment plan might be different. So, for example, if somebody has a big autoimmune component, then I might treat them with like a DMARD, like a disease modifying anti-rheumatic drug, which are sort of the classic anti-autoimmune drugs. But if somebody comes in and they look like maybe they have a large sympathetic component, we might offer a sympathetic block. Or things like so. I think like even though they might look the same, they might look a little different. They might sort of meet criteria differently, but it's also a way to kind of think about treatment.
Yes, and that is a great way for us to segue to a discussion about the treatment options. So it seems like there are three major categories, and I'd like to name them off, make sure they're correct, and maybe have you comment on them. So it seems like one big category is maybe we'll just call it neuromodulation, like physiotherapeutic treatment, behavioral therapy. Another one would be medical, so different types of pharmaceuticals, and then interventional measures. Does that seem like a good spread? But feel free to answer any way you want, Dr. Tawfik.
Yeah, I mean, I'm kind of going back to my Stanford. We sort of talk about like legs of the chair, and that you need sort of part of each to sort of have a valid and a strong treatment plan. So I think of like medications, physical therapy, occupational therapy, pain psychology, and the fourth being sort of like alternative treatments, acupuncture, that kind of thing. So I think and interventions as well. So I think that we can talk about each one, or I don't know if you want to ask specific questions about.
No, let's just like talk briefly about each one. I think that'll be really interesting.
So I mean, for CRPS, I would say there's like the things that are common for many different pain types. So, for example, tricyclic antidepressants or serotonin norepinephrine reuptake inhibitors, SNRIs, the gabapentinoids. There's sort of the common pharmacologic treatment that we use for many different types of pain, and I think are totally important for the treatment of CRPS. But I think maybe where it's more interesting is that there are some CRPS, I'd say, more specific treatments. And the sort of two big ones I would say is one is oral steroids. Again, for patients who come in early and have that sort of red hot swollen phenotype, oral steroid taper tends to take care of a lot of that initial swelling that can really inhibit a patient from being able to do effective physical therapy. So that's a big one. And then the second is the use of bisphosphonates. And these are medications like Fosamax, which is also alendronate. And alendronate is used for osteoporosis. And in patients with CRPS, there's pretty good evidence that family of bisphosphonates is actually disease modifying in early CRPS, especially in patients who come in with osteopenia on an X-ray. So that's kind of like the two, I'd say, more CRPS specific. The other big one that people always ask about is ketamine. I mean, I know ketamine is all over the news for treatment for depression, but it has been used for many years for the treatment of CRPS based on a few studies that were done about 10 years ago now, showing improvement in 3 and 6 month outcomes in patients with CRPS who underwent ketamine infusions, either on an inpatient basis or an outpatient basis. And so there's that sort of maybe aiming more at the central sensitization or sort of the central nervous system mechanisms as opposed to the peripheral mechanisms, which would be more what the other two medications would do, the steroids and the bisphosphonates. And then there's, the sort of simple things I'd say is like, vitamin C has reasonable evidence for after a fracture, taking 500 milligrams a day of vitamin C for the first 2 months after an injury seems to be protective. And so maybe it's, through I think unlikely analgesic mechanism, but maybe through an antioxidant mechanism, but it does seem to be useful. And, always thinking risk benefit, there's probably no big risk of taking vitamin C for a couple of months.
And then what are the usual behavioral therapy treatments that people benefit from? Like CoCo
So
talks
for
about
CRPS,
immunotherapy. Yeah.
I would say the absolute like physical therapy, occupational therapy, hand therapy for CRPS is like number one, number two, and number three. Like it's
Mm,
absolutely the most important. And a lot of the medications and procedures that we do, the interventional work, is to get the patient feeling good enough that they can really rehab, because you can get contractures, you can get weakness, loss of range of motion associated with CRPS, and that really needs to be worked on. And again, also this cortical representation issue. So there are different approaches. We've already talked about the limb laterality recognition, mirror therapy. Some patients are having so much pain that actually even those, some simple physical therapy maneuvers might be too difficult. And so they even have programs where they do imagined movements, like picture yourself walking down the street. We're not going to walk down the street, but just picture yourself walking down the street. And that type of like slow exposure to movement is sometimes needed. So really, really important. Hand therapists are also really, expert in the treatment of CRPS. So they will do a lot of different types of maneuvers in terms of like, strength training and range of motion work, massage, things like that to help patients get back their function. I even have some patients who have done like zero gravity type weight bearing to get back to their ability to actually bear full weight on their injured limb. And so there are, lots of different approaches, but definitely finding a great PT and OT hand therapist who've heard the diagnosis CRPS before is really important.
right.
And then from a psychological standpoint, I mean, we're very lucky at Stanford to have a great group of pain psychologists, and they really work with patients on many different things, sort of putting it all together, I would say. CoCo spoke, very eloquently about sort of that identity of being an athlete. And, most of my patients are not professional tennis players, but, people identify a lot with their activities that they're able to do, with the types of work that they do, with, even just, pastimes like gardening. And so I think the pain psychologist can be very helpful in sort of navigating the loss that comes with, having this type of condition, even if it's short term, and really working on pacing to try to, not get back directly when you're feeling better, but sort of pacing activity and sort of coping mechanisms for some of what they're experiencing.
And since we are anesthesiologists, I definitely wanted to make sure that I ask you about various interventional strategies. And it might be that they're just for the short term, but any thoughts about that?
Yeah, so there definitely are many interventional strategies. So I think the sympathetic blocks are probably the sort of first thought we have as anesthesiologists, because again, we sort of equate CRPS with this sympathetic component. And so definitely, performing stellate ganglion blocks at the neck for upper extremity CRPS and lumbar sympathetic blocks for the treatment of lower extremity CRPS. And there's reasonable evidence for both of those. Sometimes patients need to have a series of these blocks in order to actually get a prolonged benefit, but they're very reasonable procedures, when done under guidance. So a lot of the times we'll use fluoroscopy for the lower extremity lumbar sympathetic blocks, and ultrasound or fluoroscopy for the stellate blocks. I think that is definitely something that many anesthesiologists are very well versed in and trained in. So that's something that's quite common. And then the other big category is really neuromodulation. And I think neuromodulation has come a long way over the past probably 6 or 7 years, where there's so many more new systems for dorsal column stimulation using high frequency approaches. And then dorsal root ganglia stimulation, which allows the targeting more of specific nerve roots. And so those two together, I'd say, have really changed the way we use neuromodulation. And there is pretty reasonable evidence for improvement, long-term, like 6 months or 12-month improvement in CRPS associated pain. Most of the studies have been done in lower extremity with neuromodulation, either dorsal column or DRG, dorsal ganglion stimulation. And then I'd say kind of the exciting to me, like kind of the future may actually be peripheral nerve stimulation. We don't have time to talk all about this, but one approach that we're really interested in at Stanford is really diagnosing the specific nerve that may be contributing to complex regional pain syndrome in a given patient. And if we find a given nerve, then we can sort of offer more targeted treatment. And these peripheral nerve stimulators are just simple electrodes that are placed percutaneously through a needle, and can basically override this sort of hyperexcitability of the peripheral nerve. And that's something that we've been using more and more frequently here.
Very cool. Well, I definitely wanted to ask you about what you feel are the upcoming therapies. And of course, you do research in this area. So maybe you could share with us what you think the future is going to be.
Yeah, I mean, my lab is particularly interested in glial cells, as I mentioned. And so we're doing a lot of transcriptomics right now to try to find, specific targets in astrocytes and microglia that might be potential for development of therapeutics. The nice thing about those cells is that they're sort of bystander cells in a way. They're not required for transmission of neuronal information. So you can imagine if you just, with like regional anesthesia, you just block a nerve, well, then you don't feel anything. So most people want to be able to feel their foot and move their foot. So the nice thing about using glia as a target is that you can maybe modulate the neuronal transmission as opposed to just completely shutting it down. So that's kind of an area that we're moving in terms of our own research, although we're, really on the preclinical side. I think in general for CRPS, there is a move towards these immune modulation therapies. I sort of alluded to the idea of using DMARDs. I think that there are a lot more people who are getting comfortable with that idea, and then using these more sort of CRPS specific medications, and then really integrating the whole thing, the medications with the physical therapy, with the pain psychology, with the interventions, and really trying to provide multidisciplinary therapies for patients.
Yeah, it definitely sounds like it takes a village sort of thing. Many people have to be involved. Let me ask you if you have any sort of concluding like take-home messages for our audience about CRPS.
I guess I would say that, just think of it. If you have a patient who keeps coming back to the ER and saying, "Oh, my cast is too tight," they call a pain consult, they keep saying their cast is too tight. Or you hear that story of like, I can't even, put a t-shirt on. I have to wear a tank top because it's so painful to have, the cloth touching my hand. Just think of it. And I try to give lectures to the surgeons here and sort of around the country when I have the opportunity. And I just sort of say, especially when I'm lecturing at Stanford, like, send me the patients. Like, the worst case is you're wrong and it's not CRPS. But if you're right and we catch it early, then there's so much more we can do for this patient. And so, I just kind of think again about like risk versus benefit. Like, what's the risk of sending a patient to a pain specialist for a rule out CRPS consult? There's not a whole lot of risk. But the potential benefit is large if you're earlier to diagnose that patient with CRPS.
Such a good point. Thank you so much for that. And it's not something that most places or an office is going to be equipped to deal with because you need a lot of specialized members of the team to do this. So that seems to me to be the biggest take home. And that, there are powerful instances where people manage to do this in time, get diagnosed in time, get treatment, follow through with the treatment course, and come back to win tennis tournaments. So I wanted to wrap this up, but I want to thank both Dr. Tawfik and CoCo Vandeweghe for participating in this. I just feel like this is such a incredible story, incredible journey. It's a disorder that is so mysterious, but there is a way to get through it. And thank you both for sharing that with the California Society of Anesthesiologists. All right, take care.
No problem.
Thanks for hosting.
Thank you.